Today's topic, making sense of modifiers. And I want to introduce to you Christy Pollard. She's a senior consultant with more than 20 years of industry experience. She's responsible for the development of web-based and instructor-led training materials, as well as conducting training in ICD-10 CMPCS and CPT, and performs DRG and APC audits. Christy has an extensive background in coding education and consulting, and she's a national speaker on topics related to ICD-10 and CPT coding, as well as code-based reimbursement. She has designed and developed training programs for inpatient and outpatient hospital-based coding, including vascular interventional radiology, interventional cardiology, orthopedics, and obstetrics. At this time, Christy, I think I'm going to turn it over to you and have you kick us off for today's webinar.
All right, thank you, Kathy, and thank you everybody for joining us today. As Kathy mentioned, today's presentation is on modifiers, and I know that that's a hot topic that a lot of people have questions on. And this is a presentation that was developed specifically for hospital modifier reporting because it is very different from what we see on the pro-fee side. And we're going to be digging a little bit further than the CPT book today because there are quite a few modifiers that have different meanings under OPPS and in the hospital outpatient setting than they do on the physician side. So the objective slide just shows you a couple of the topics that we're going to be hitting today, but I am going to be going through a fairly comprehensive list of modifiers. And since this is going to take us a while, I guess we'll just go ahead and get started. So to let you know where this presentation came from, it really was born out of some questions that I had received and questions that I had seen from other coders, both experienced and novice coders. In particular, I was kind of struck by some questions that came up on an HEMA Engage site. And the questions were pretty broad. You know, when are modifiers applied? And how do you even begin to answer that question? How do you decide when one modifier is more appropriate than another? And more importantly, I think, is which modifiers are appropriate for resolving NCCI edits? And I'm sure you're all thinking Modifier 59 right now. We're definitely going to talk about that as well as some of the others. So some of the information that I cover today may seem kind of basic, but there's a lot of information floating out about how to use modifiers in the facility outpatient setting, and you may not know where to find that specific information. So you may have heard this is what we do, but you don't know why it's what we do, and that's what I would like to get to the bottom of today. So a couple of things about modifiers to kind of help answer that first question from the previous slide. When are modifiers used? Well, they're used to help tell more about the patient's story. And if you've listened to my webinars in the past, you know that this is something that I say repeatedly, that our codes are used to help tell the patient's story, because once that data moves on to the insurance company or to people who are analyzing data for statistical purposes, they don't have the chart anymore. All they have is that list of codes, and they're trying to piece together what's going on with that patient based off of what we've reported in codes. So a couple of things. First of all, most of the information that you will find about assigning hospital modifiers in the OPPS or outpatient setting come from the Medicare Claims Processing Manual in Chapter 4. And I'm going to walk through how to find that here in a little bit so that you can learn how to pull this information yourself. First of all, if you answer yes to any of these questions, then you should be using a modifier. The first one is, will the modifier add more information regarding the anatomic site of the procedure? And I would say that one of the things we see missing most frequently on CPT codes are the anatomical modifiers for either a specific body part or for a side of the body. Will the modifier help to eliminate the appearance of duplicate billing? So you may have the same CPT code reported a couple of times. It's your way of showing that this wasn't a mistake, that we really did mean to report a code 2 times instead of just 1. And then finally, would the modifier help eliminate the appearance of unbundling? And I think that's the biggest place where we see modifier usage, and it's the one that receives so much attention because it is tied into billing and denials. And that one, obviously, we're going to talk about a lot today. So resources for modifier use. If you learned about modifiers in school and then got into the real world and started working in a hospital and realized that there were more modifiers than what was shown in the back of the CPT codebook, then you may be wondering where these come from. So here are the resources for the use of modifiers. The CPT book, first and foremost, it does have a list of modifiers approved for hospital and ASC use. It is a different list than what we use on the pro fee side. The HCPCS Level 2 code list is another resource because it's not just CPT modifiers. We also have HCPCS Level 2 modifiers. And if you don't purchase a HCPCS Level 2 codebook every year, have no fear. As a matter of fact, there's really no need to, because those codes and modifiers are updated quarterly and they are available on CMS's website for free. You can just download an Excel file and view those without having to pay the $70 or whatever it is they're charging for a level 2 HCPCS book. Now those list out all of the modifiers. The CPT book gives you a little bit of instruction on how to use the modifiers that are shown there. HCPCS Level 2 does not give any modifier instruction, but the Medicare Claims Processing Manual is one of the internet-only manuals from CMS, as well as Medicare transmittals have the bulk of the information that we need in the hospital setting for using those. You will also find information in the NCCI policy manual. So you're probably all very familiar with the NCCI edits that pop up as you're coding using the encoder or in your billing software. Well, those are also located in Excel files on CMS's website. And not only that, there is a manual in PDF format for every chapter of CPT that explains what you can and can't do. And if you've ever wondered what the rationale was behind some of those CCI edits, it's likely that you would find it within the policy manual. And I think this is what makes modifier usage so hard, is that we've got so many different places that we need to look. Another place that is not listed on this slide but is a good resource is your individual MAC. Your Medicare administrative contractor a lot of times will publish information on their website, fact sheets, and other information on the use of modifiers. So first thing that I want to walk through, and my apologies if you are familiar with this process and you're wondering why I'm starting here. I just find that most coders are not aware of how to locate the Medicare Claims Processing Manual. I guarantee we're going to get into individual modifiers here in just a few minutes, but wanted to show you where I pulled some of my resources for today. So if you go to Medicare's website, cms.gov, on their homepage at the very bottom, they have their top 5 resources. And the very first thing on that resource list is manuals. And you'll see that I did a screenshot off of my computer, and you can tell which links I click on frequently because they're purple instead of blue. Number 1 is manuals, and number 2 is the Medicare coverage database. The manuals, if you click on that, it is going to take you into this page, and off to the left, there's a box that has internet-only manuals, or IOMs. And if you click on that, it is going to take you into a list of the internet-only manuals. And the one that we want to click on is 100-04, and that is the Medicare Claims Processing Manual. And this is kind of a peeling the onion kind of a thing. You click on one thing and it, gives you another list and another list. If you click on the Medicare Claims Processing Manual, it will give you a list of several different chapters, and they give instructions on how to process claims for pretty much any type of healthcare institution that is going to submit a claim to Medicare. We are going to click on Chapter 4, which includes Part B hospital, including inpatient hospital Part B and OPPS. But if you work with critical care or critical access hospitals, there's a chapter for that. There's a chapter for hospital inpatient. There's a chapter for general processing of the UB04. Anything you ever really wanted to know about how to process your, or how to process your claims, and in some situations assign codes and condition codes and all that, is found here. So the Medicare Claims Processing Manual has a treasure trove of information for us in the hospital setting on how to use modifiers. And that will bring us into our first polling question. Kathy, will you launch the poll, please?
Absolutely. So our first question for our audience today, so what's the best resource for using modifiers in the facility setting? Is it the CPT book? Is it the Medicare Claims Processing Manual? Or is it Google? So what do you think? What's the best resource for using modifiers? Your CPT, Medicare Claims Processing Manual, or Google? Oh, and we got lots of colors coming through, Christy. We've got lots of responses trickling in. I'd love to see that. So we're getting over to the majority of you. So what do you think? And we've got all colors, all choices. So this will be some good discussion. So anybody else want to weigh in? I always like to get to that magic percentage. So what's the best resource for using modifiers in the facility setting? Your CPT, the Medicare Claims Processing Manual, or Google? Okay, you've slowed down. I'm going to close the poll. It's your last chance. 3, 2, 1. Christy, we've got the majority. It's 72% is saying it is the Medicare Claims Processing Manual, but we've got 22% saying the CPT book, and a small percentage is saying Google.
Okay. And I just kind of threw Google in there. I will admit that I have used Google when I'm desperate. But Google, because there's so much information out there and it's not all good information, I would be really cautious with using Google. The CPT codebook does have some information on modifiers, but here is the snag we run into with CPT. CPT is a coding system that was developed by physicians for physicians, and most of the modifier advice that you will find written throughout the CPT book applies to physician coding settings and may not apply to hospital. So for hospital OPPS reporting, I think that the Medicare Claims Processing Manual provides the best information where CPT falls short. And again, you know, it's because CPT was developed by physicians for their use. So of course, it's going to be very physician reporting centric, if that's a term. Thank you, Kathy. If you'll bring me back into the presentation, we will move on and start talking about specific modifiers, beginning with modifier 25. And what you see with my little pink dragon here is my attempt to have fun in a really not kind of fun topic. But our pink dragon is holding up a sign that has the description from the CPT book on modifier 25. By the way, all of our CPT modifiers are numeric. Our HCPCS level 2 modifiers are alpha or alphanumeric. This modifier 25 is a significant separately identifiable E&M service by the same physician or another management service by the same physician or other qualified healthcare professional on the same day of the procedure or service. And if you're like me and you read that, you probably go, huh? There are a couple of different things. First of all, it's added to an E&M code when there is another separate service that has a status indicator S or T on the claim. Our S and T status indicators under OPPS are those those procedures that are surgical in nature. Your E&M procedure must meet the definition of a significant separately identifiable E&M service according to CPT. And I think that this is really hard to figure out without a scenario. So let's look at a couple of scenarios. In our first example, our little pink dragon has gone to the ER with a headache and a stiff neck. They had a level 3 ED visit for headache and stiff neck with a lumbar puncture to rule out meningitis. And most of your ED cases will have a modifier 25 if they do perform another procedure that has an S or a T status indicator. So the code that we're looking at for an S or T status indicator is the 62270, which is a surgical type of procedure. And it is going to require this modifier 25 on our level 3 ED in order to bypass. Now, the reason that I'm saying most cases will require a modifier 25 is because the doctor doesn't know what's going on with that patient until he examines him. So he brings the patient in, he does the medical history, they do whatever it is your criteria is for assigning a facility level E&M. And then he decides based off of all of that they're going to do a spinal puncture. So in this case, we can add a modifier 25 and it goes on the E&M code. Now, clinics are a lot harder, and I've seen modifier 25 be misused in wound care clinics since it is one of those clinics where we see procedures. So you've got wound care clinic visit for active wound care management using non-selective debridement under an existing plan of care. And the code for that is 97602. And wound care is a completely whole different webinar, by the way. As a matter of fact, we've got one in our archives somewhere that I think is still out there available for purchase. But the wound care is something where if the physician and the staff is operating under an existing plan of care, you don't assign an E&M every time they come in. It's bundled into the fact that they know that there's an ulcer, they're treating the ulcer with non-selective debridement. However, on the right side of our screen, we have a wound care clinic visit for active wound care management with assessment of a new ulcer and subsequent non-selective debridement, which usually ends up initiating a new plan of care for this new site. In that case, we can report a facility level clinic E&M with modifier 25 in addition to our non-selective debridement code. So while it may be rather automatic that you put a modifier 25 on your ED E&Ms, it will not be for clinics. Now, that doesn't mean that you shouldn't have a coder who is trained in the usage of codes and modifiers putting these modifiers on there. What we want to avoid is having a billing department that says, oh yeah, there's an edit, we need to stick a modifier 25 on the E&M. You do need to review medical record documentation and make sure that the documentation supports the use of the modifier. Modifier 27 is one that I think gets used a little bit less. It is, or maybe a lot in your facility, depending on what's going on. But this is multiple outpatient hospital E&M encounters on the same date. And if you have an encoder that subscribes to Coding Clinic, you probably also get Coding Clinic for HCPCS. And if you're not reviewing that and are not familiar with it, it's an excellent resource for us on the hospital side because it is specifically looking at CPT coding, HCPCS coding, and modifier usage for the hospital outpatient setting, and it's very OPPS centric. So if you are an OPPS facility, it's a great resource for you. So Modifier 27 was originally created to identify hospital facility reporting in a situation where the patient is receiving multiple E&M services either by the same or a different physician in multiple outpatient hospital settings on the same day. And this it gets kind of complicated when you get into, I've got a note here about it does not replace the need for condition codes G0. And if you read that and you wonder, well, what does that mean? What is condition code G0? This is the kind of thing that you go back to the Medicare Claims Processing Manual and it will tell you how you need to report these. So condition code G0, it goes on the UB when you have multiple medical visits that occurred on the same day in the same revenue center, but the visits were distinct and were separate and independent visits. So for example, you have a patient who goes to the ER twice in the same day, once in the morning for a broken arm and later for chest pain. So those are two completely unrelated conditions. So multiple visits on the same day in the same revenue center may be reported on separate claims, is what Medicare is saying. But when you do that, you report condition code G0 so that it will get paid appropriately. But if you have a patient who comes in with two E&M services that are related, then you would use your modifier 27 on the second claim form. Moving on to laterality modifiers, which seem really simple and straightforward. We've got an LT, RT, and 50. It's either left side, right side, or bilateral. The problem is that I've seen these misused a lot. Remember that modifiers are used to give you more information about what's going on with the patient. And the Medicare Claims Processing Manual gives us a little bit of information on how to report these codes or these modifiers. First of all, they are used to report procedures performed on paired body organs. You've got 2 ears, 2 eyes, 2 legs, 2 arms, 2 kidneys. You do not have, you could argue that you have 2 sides of the body, but those sides of the body are not paired organs. So you got to be kind of careful with applying these laterality modifiers. The way that I see them misused is they're put on codes that don't have a body part in them. I see it a lot in vascular interventional radiology for the selective catheter placements. None of those codes specify a particular vessel, so the RT-LT modifiers don't really add anything to that code description. I also see them added on codes that have multiple body parts listed, and for which not all of those body parts are paired organs. The best example of that would be if they removed a right cheek lesion. The right cheek lesion, the code for that removal does not specify, or specifies several different body parts. I think neck might be in with that. That is not a paired body organ. So just kind of be careful with that. Modifier 50 is our bilateral modifier, and you've got to be careful with slapping that modifier onto a code, because when you do, it gives you double payment. And if you have a procedure where the code description says bilateral, then that is inherently bilateral and you can't modify it. And I already talked about not using the modifiers of multiple body sites. So let's look at a couple of examples of the laterality modifiers. We have a bilateral radical mastectomy. The code with the description is shown here, code 19305. We add a 50 modifier to show that that was done on both sides. Bilateral vertebroplasty at the L3 level is assigned code 22511, but in this code description it specifies unilateral or bilateral, and we cannot append any modifiers to this. It's not going to require a modifier, and we're going to get paid the same whether it was one or both sides. For left knee diagnostic, our left diagnostic knee arthroscopy with right knee arthroscopic meniscectomy, and I don't know if a physician would ever do this, do one on both knees, but if he did, you've got the surgical it's 29881 with the RT modifier and 29870 with an LT modifier. These two codes together, by the way, do generate a CCI edit. The diagnostic knee arthroscopy is a component of the meniscectomy, but because they were done on opposite legs, adding the RT and LT modifiers show that they're separate, and it satisfies that CCI edit without having to add a modifier 59. So this is one of the ways where we can avoid using modifier 59, which is coming up. I will talk about it, I promise. Modifiers for discontinued procedures represent one of the biggest changes between physician and hospital reporting. Modifiers for discontinued procedures are 52, 73, and 74. On the physician side, they use modifiers 52 and 53. And there are some procedures, I'm thinking of the GI endoscopy procedure codes, where the instructions in the CPT book tell us to use modifier 52 and 53 in different situations. Those apply to physicians. And the problem is that it doesn't really tell us, oh, this is for professional fee coding only. And unfortunately, they don't tell you how to code for it on the hospital side. Again, on the hospital side, we are referring to the Medicare Claims Processing Manual. We're referring to our HCPCS, our coding clinic for HCPCS, to figure out how to code some of these. And so I want to spend a little bit of time on these discontinued procedures. The difference between modifiers 52, 73, and 74 are the definition that we use for 52 is reduced services. I'll come back to that in a minute. Modifier 73 is a discontinued procedure prior to administration of anesthesia, and modifier 74 is a discontinued procedure after anesthesia has been given. And the Medicare Claims Processing Manual has the documentation that tells us that modifier 52 is used when a procedure is discontinued and anesthesia was not planned. And then it kind of gets into that, well, what is anesthesia? And they define that as well. So according to the Medicare Claims Processing Manual, anesthesia is local, regional, moderate sedation, deep sedation, or general anesthesia. That pretty much covers everything. So you can see that there probably aren't a whole lot of times that we're going to be using modifier 52, because most procedures that we do in a hospital setting do require anesthesia. Now I realize that there are some things in radiology and things like that where they may not give them even a local, and that's where you would be using or seeing modifier 52. So let's look at our canceled and discontinued procedures, because I find that people really get confused when it comes to that Z code for canceled procedure versus the use of these modifiers. And we're going to look, so we have elective cancellation, and if you have an elective cancellation, which is usually, you know, patient decision, physician decision, contraindication, they never even got close to doing the procedure, you don't assign a CPT code for those. You report the canceled procedure ICD-10-CM code, which is in category Z53. No CPT code goes on that claim. Modifier 52 is partial reduction, cancellation, or discontinuation of services, again, when the anesthesia is not planned. Modifier 73 means that the patient was prepped for surgery and taken to the OR or the procedure room, but the procedure was canceled before they could induce anesthesia. What this modifier does to your OPPS payment is it reduces the APC rate by 50%. Modifier 74 is the procedure cancellation after induction of anesthesia, and when you append modifier 74 to your procedure code, you get 100% of the APC rate under OPPS. You can see that that makes a pretty big difference in payment between modifier 73 and 74. By the way, modifier 52 pays at a 50% rate as well. So let's look at a couple of examples. An example of elective cancellation. We've got our little pink dragon here who's come in to have a laparoscopic tubal ligation. Oh, she's a girl. I guess I should have guessed that because she's pink. The problem is she had some cereal for breakfast, and you can see she's got a big old bowl of cornflakes there. And so the doctor said, no, we're not doing your procedure. We're going to assign the Z53.09 code because the procedure was not carried out because of contraindication. You would add a secondary ICD-10 code here to show why the patient was supposed to have the surgery, but no CPT code. So too bad. You ate your cornflakes and you don't get a CPT code. An example of Modifier 52. This one's kind of an interesting one, and I pulled this one from a Medicare transmittal. There is a HCPCS code for setup of an infusion pump for chemo at home, code G0498. And it happens to include initiation of the infusion. But what if you bring the patient in, you set up the infusion pump, but you don't start chemo? Well, this is a situation where they recommend using Modifier 52. So you're basically getting paid for setting up the infusion pump, but you're not getting paid for any of the infusion of the chemo drug. An example of Modifier 73, patient was taken to the OR for a laparoscopic cholecystectomy. Prior to anesthesia induction, the patient was found to have AFib and the procedure was canceled. In that situation, we would assign the code for the intended procedure, which was a lap chole, and add Modifier 73 to show that it was discontinued before anesthesia. And again, you'll get 50% of the payment for that lap chole for that procedure. An example of Modifier 74, patient was taken to the OR for robotic-assisted transurethral resection of the prostate, and after induction of anesthesia, the equipment was noted to be malfunctioning, and so they canceled the procedure. Well, since the patient got anesthesia, we code the intended procedure and put a Modifier 74. And you can see that documentation from the physician is going to be important here too, because we need to know what the intended procedure was if we're going to assign a CPT code. And again, for Modifier 74, you'll get 100% payment for that TURP. We can't really have a discussion about discontinued procedures without talking about unsuccessful procedures, and this happens quite a bit. You have a procedure that was performed, but it did not achieve the desired results. And modifiers 73 and 74 don't apply in this situation. You still assign the CPT code, even though it was unsuccessful, regardless of the number of attempts. Couple of examples that I pulled from Coding Clinic for HCPCS. We had bone marrow biopsy, but when they did the aspiration, nothing came out. How many times have you seen that in documentation? Another example, lumbar puncture, but they didn't draw any fluid. It's like, well, dude, what do I code? Well, they did the procedure. I mean, they stuck a needle in, they probably gave a local anesthetic at the same time, or even sedation if they did a bone marrow biopsy. I'm not quite sure what they do for that. But notice that no modifiers, the procedure was done, it just didn't achieve the desired results. Another example of this that I don't have written on the slide would be an angioplasty where it didn't work. They went in, they inflated the balloon, and they said, okay, this is not going to work. We're going to have to go do a bypass. But remember that it doesn't matter how many times they tried it and it didn't work. You can only code for it once. And by the way, I should say on the angioplasty, that doesn't count angioplasty that didn't get them the right results, so they put in a stent. I mean, that just codes as a stent. Okay, Kathy, that brings us to polling question number 2, please.
Okay, here's our question. Modifier 52 is used for procedures canceled before the patient goes to the OR. Is that a true statement or false? Modifier 52 is used for procedures canceled before the patient goes to the OR. Do you think that's a true statement or a false statement? Christy, we've got responses trickling in. Again, I've got some color. I think we're going to have lots of discussion. I got responses still coming in. So what all do you think out there? Modifier 52 is used for procedures canceled before the patient goes to the OR. Is that true or false? Boy, we got slow and steady responses coming in. So great. Love to see it. We love this interaction portion of the webinars. So we love when you guys have some responses out there for us to discuss. So anybody else want to weigh in? Here's your last chance. I'm going to close the poll. 3, 2, 1. Christy, this will be interesting. We've got the majority at 65% saying this is a false statement, but we do have 35% of our audience is saying it is true.
Okay. So on this one, remember that it's kind of a trick question, actually. Modifier 52 is used for procedures that are canceled and the procedure was not to require anesthesia. If the patient's going to the OR, then they probably are getting anesthesia. So the answer to this one is false. It really has, Modifier 52 has nothing to do with where the patient is when the procedure is canceled. It has everything to do with whether or not they were going to get anesthesia for that procedure. All right, Kathy, thank you very much. So Modifier 58 is the staged or related procedure or service by the same physician or other qualified healthcare professional during the post-op period. And this one, you know, kind of drives me a little nuts. I was wondering when we would ever use this. For the longest time, I could not find a good example for this particular modifier. But the instructions are that it gets added to the subsequent procedure code for staged or related procedures within 24 hours of a primary procedure. And the indications for that would be a planned or staged procedure, a more extensive subsequent procedure, therapy following a surgical procedure, diagnostic endoscopy resulting in the decision for open surgery, but not used for a failed laparoscopic procedure that is converted to open. So let's talk about a couple of examples of when this would be used. And these are examples that I pulled from Coding Clinic for HCPCS. First of all, if you have a patient who comes in and they have a needle core biopsy of the breast and it comes back as a fibroadenoma, so they decide to take the patient back and do an excisional biopsy or removal of that entire fibroadenoma, that would be a situation where you add the 58 modifier to your excisional breast biopsy to show that, you know, we did the needle aspiration, but oops, yeah, we confirmed pathology and we need to take the patient back. Now this is different and it has to be on the same within 24 hours. So you might want to highlight that if you have this printed out. That is different from the patient who comes in with diabetes and peripheral vascular disease and has 3 gangrenous toes removed from her left foot, but then 2 days later comes back and has amputation of the entire foot. That's not within 24 hours. That's not considered to be a staged procedure. So you're really using Modifier 58 within a single outpatient episode. Modifiers 76 and 77 are the repeat procedure modifiers, and I think they are some of the most underused modifiers out there. I can almost guarantee that each one of you is using a modifier 59 right now when you should be using a modifier 76. So if that kind of just blew your mind, then stay tuned because we're going to talk a little bit more about this. Modifier 76 is repeat procedure by the same physician. 77 is repeat procedure by another physician. And these modifiers are used when you repeat the exact same CPT code. If we go back to that, one of those initial slides that I brought up where I said that according to the Medicare Claims Processing Manual, one of the indications for using a modifier is to prevent the appearance of duplicate billing. And these are the modifiers that we use to prevent the appearance of duplicate billing. And the way this goes is you report the exact same CPT code twice, and you add a 76 or a 77 modifier onto the repeated code. So if you have a physician who's doing the exact same procedure on multiple body parts, and you report the exact same CPT code on multiple body parts, you should be using modifier 76. You should not be using modifier 59 for that. And my source for that is when they brought out the X modifiers a few years ago, one of the MACs had a webcast where they talked about modifier usage. And, you know, everybody says that modifier 59 is frequently misapplied, but they never really talk about modifier 76 when they're talking about it. So I'm going to put that out there right now. Modifiers 76 and 77 are not NCCI related modifiers. They do not satisfy CCI edits. And when you report a CPT code twice, it doesn't generate a CCI edit. It just kind of looks like a duplicate billing to the insurer. So modifiers 76 and 77. Modifier 91 is the lab modifier, and it is used when a lab test is repeated and it's reported with the exact same CPT code, and the modifier gets added to the second code. This is one of those areas where looking at your payer websites can be very useful, because they have some information and they may have some fact sheets. So just before the webinar today, I did a quick Google search, because I did say that I use Google on occasion, and came up with a fact sheet on the Novitas website. So if Novitas happens to be your MAC, just know that they've got a fact sheet out there on their website, and it talks about what you need to know about modifier 91, appropriate uses, inappropriate uses. So there's a big old clue from your payer. Claim submission instructions, claim processing, and they even give an example. They happened to give an example of multiple blood tests performed to check a potassium level after potassium replacement and low-dose insulin therapy. And then after the initial potassium value was measured, they did 2 more blood tests on the same date of service, and they coded 84132 3 times and added modifier 91 to the last 2 codes. So your first code doesn't get modifier 91, but your second and third do in that situation. The anatomical modifiers, I think these are fairly straightforward. I almost didn't put these really in my presentation, but I wanted to be able to use this awesome picture of this guy who just has eyes and toes. These are the anatomical modifiers. These are HCPCS modifiers, but they do happen to be in the CPT book. Pretty straightforward. You've got modifiers for upper and lower eyelids on the left and right side, and you have a modifier for each individual toe. And I've had people say that, complain to me about the way that they're numbered, and don't take that up with me. I didn't number them, but I agree, it's messed up. Coronary artery modifiers are additional anatomical modifiers, LC, LD, LM, RC, and RI. And these should be added anytime you have a code that indicates per vessel. And it's something that I see quite frequently added to the PCI codes, the percutaneous coronary intervention codes. But then there are other codes you might not think of that are probably in your charge master, like intravascular ultrasound and OCT imaging of the vessels. Those are coded per vessel. And anytime you have something that's per vessel, you should be sticking a coronary artery modifier on there. By the way, you wouldn't think these would impact your payment, but there are some payers who are looking for these modifiers, and they will deny a claim if it's not on there. So even though it doesn't generate a CCI edit or do anything funky in your coding process, it could get denied on the back end. So make sure anytime you have a code that specifies per coronary artery, these modifiers get on there. Anatomical modifiers for the fingers. So we got our little jazz hands here. And these, similar to the coronary arteries, should be used anytime the code specifies per finger. Modifier CA, this is a really interesting modifier. And there is a list of procedures that are on Medicare's inpatient only list. And you can only code, these procedures that are on the inpatient only list, if you report them on an outpatient claim, the entire claim gets denied. But there are situations where you may need to be able to report the fact that this patient wasn't an inpatient, but yeah, we should get paid. And there are two situations. First of all of these, by the way, both situations involve emergent cases. So these are cases where the patient comes in to the hospital, probably through the ER, is rushed to the OR, they do the procedure, and either the patient expires and dies before they can admit the patient to inpatient, or their main goal is to stabilize and transfer. And so they stabilize the patient and transfer them to another facility who can better care for them before the patient gets admitted. In those two situations, you can code the inpatient only procedure and put a CA modifier on it, and then CMS will give you a single payment for the entire claim. But make sure that it meets one of those two criteria, otherwise you could be running into some compliance trouble. Okay, I promised a big discussion about NCCI, so let's talk about the National Correct Coding Initiative. If you have ever wondered and have not been out to CMS's website, where the CCI edits come from, how those little magic edits pop up in your encoder, this is where they come from. So if you go to Medicare's main webpage, cms.gov, and click on the Medicare icon, it is going to, if you scroll down, there's a section for coding, and under that is the National Correct Coding Initiative. And you can go in there, you can download the CCI edits for whichever quarter you're looking at. They are updated quarterly, which means it's April. We had new CCI edits go into effect on April 1st, but the manual that I referred to earlier is also there, that explains how to apply some of these CCI edits and when you can and can't code things together. A real down and dirty primer on the CCI, when you open up one of the CCI edit files, it's going to pull up a spreadsheet that lists three main columns. There are a couple of other columns in there that we don't really need to worry about, but your column 1 code is our comprehensive code. The column 2 is the component code. So column 1 code includes the column 2 code. And then there is a third column for modifier allowance, either a 0 or a 1. And what this means is whether or not I can add a modifier to bypass the edit. There are certain procedures that are always bundled into other procedures, and there's nothing you can do. You can't put a modifier on it. You can't report the component code. You just can't really do anything with it. So the modifier allowance 0 means I can't add a modifier. Modifier allowance 1 means I can add a modifier as long as the criteria are met. And our little dragon here is telling us modifiers can make NCCI edits disappear, and anything that makes NCCI edits disappear is a potential compliance issue. And that's why we make such a big deal out of NCCI. So if you've ever wondered, I always ask people when we're looking at Modifier 59, which code does Modifier 59 or the X modifier go on? And the answer I usually get is whichever one satisfies the edit. which I suppose is it's an answer. It's not the technical correct answer I was looking for. But if you've ever put a modifier 59 on a code and you're like, okay, it's not that one, and so you put it on the next one and it doesn't work, this is why, because it has a 0 modifier allowance. And I've had people email me and say, why can't I get rid of this edit? And I go straight to the NCCI edits to look at the Excel file, and this is why. So modifiers 59 and the X modifiers. These are the magic modifiers that make NCCI edits disappear. These are the modifiers that a lot of billers know about, because they'll say, oh, just put a 59 on it and that edit will go away. So we've got modifier 59 is the original CPT modifier, and then CMS came out with 4 X modifiers that are HCPCS modifiers that are kind of subsets of modifier 59. So we have these modifiers are NCCI associated. They were specifically developed to satisfy CCI edits. So if you don't have a CCI edit, you've got no reason to add a modifier 59 onto a code unless the CPT book tells you to do that for some reason. Their primary purpose is to indicate 2 or more procedures are performed at different sites or different patient encounters. And once again, the X modifiers are just, they provide better specificity than modifier 59. So this is the modifier of last resort. You should be going down this list in your head and thinking, okay, is it a lab? If it's a lab, it needs modifier 91. I can't use modifier 59 here. Is it a repeat procedure? If it's a repeat procedure, I should be using a 76. I shouldn't be using this. Is there an anatomical modifier that would show this as 2 separate body parts, like LC and RC for different coronary arteries? If so, then you shouldn't be using modifier 59. And I say modifier 59, but I'm also inclusively including all of the X modifiers there as well. Are you using modifier 59 or X modifier? That is really up to your payer and up to your individual MAC. I would say it's about 50-50. I've heard some consultants say MACs aren't really paying attention to them. Those consultants happen to work, I have noticed, on the east side of the country. And it seems like the MACs who have jurisdictions in the eastern part of the country may not be using them as much. We work with a lot of clients in the western half of the United States, and they are using them, where it's kind of hit and miss. So you really need to know what your payer is looking at. These, looking at the individual modifiers, let's look at examples of how to use the X modifiers. If you aren't using X modifiers, then on all of these examples that I'm about to give you, would use modifier 59 instead. But I think the X modifiers are harder to understand. So the XE modifier is a separate encounter. And the example given here is a 6-year-old with a tonsillectomy who comes back into the ER that evening for control of post-tonsillectomy hemorrhage. If you happen to, these claims will be combined into a single outpatient encounter when it goes to be billed, and it will shoot something back at you that says, that control of hemorrhage is bundled. And so we have the XE to show that it was a separate encounter. An example of a separate practitioner, the XP modifier. Patient came into the ER with obvious ulnar deformity following a car accident. Dr. Green did a closed reduction in the ER, but it didn't work. And remember, we still code it, even though it didn't work. It was unsuccessful, but we still did the procedure. Then the patient went to the OR where Dr. House did an open reduction with internal fixation. If you code an ORIF along with a closed reduction, you are going to get a CCI edit saying that you've unbundled the service. So we can add the XP modifier onto our ulnar shaft fracture or our closed treatment to show that it was a separate practitioner who performed that procedure. Notice that's not the same CPT code. This generates a CCI edit. If it had been 2 closed reductions, same CPT code, it would have been a modifier 77 since they were done by different doctors. An example of the XS modifier separate structure, a great example, colonoscopy with biopsy of the sigmoid and snare and polypectomy in the cecum. The biopsy is a component of the polypectomy and will generate a CCI code. So we're going to add the XS modifier onto the biopsy. By the way, the modifier 59, the correct answer is it goes on the lesser of the two codes. It always goes on the component. And the way I remember that is that component code is not big enough to stand up on the same level as that comprehensive. So we got to give it a couple of extra digits so that it can hold its own. An example of modifier XU, unusual non-overlapping service. And I get the same question on this. What does this mean? And my answer is I don't know. But from what we have deduced in looking at examples of when to use this, this is kind of like the catch-all. So XE doesn't apply, XS and XP don't apply, XU, it then becomes your modifier if your payer is requiring the X over the 59 modifier. And the example I have here, a patient with claudication and rest pain went to interventional radiology lab for a lower extremity angiogram. Angiography showed stenosis and the angioplasty that angiogram is bundled into the revascularization procedure, but since it was diagnostic and the decision to do the angioplasty was made based off of the imaging results, they can be reported separately. The XU modifier goes on the angiography code. Now, an example of misuse of modifier 59, and I've seen this where we have angioplasty and stenting of the LAD and angioplasty of the right coronary artery, and the coder reported a code for the angioplasty and the stent separately and realized that there was a CCI edit. So she put an XS or a 59 modifier on the angioplasty. And did it satisfy the edit? Yes, it did. Did the claim get paid? Probably did. Is it correct? It is not. Because we can add anatomical modifiers here and that will bypass the edit. So remember, modifier of last resort. You should be asking lots of questions before you put a modifier or an modifier 59 or X modifier on the claim. It is a compliance target. If all the government has to do is run all their claims data and see how many times you reported modifier 59. And if they think it's too high, then they have a reason to come investigate you. So the questions you should ask, is there a CCI edit? If yes, then your 59 or X modifier may apply. Notice I said may apply, and it's not automatic. You've got to review that documentation. If no, use modifier 76 and 77 for your repeated codes. And if you're still having trouble with that, you can email me and we could talk about it on email later. But I know it's kind of a mind switch because I had this same thought process a couple of years ago where I was like, what? That can't be right. Will any other modifier satisfy the edit? If yes, then don't use modifier 59. If not, then your modifier 59 X modifiers may apply. Does the NCCI modifier have a 0 allowance? If it does, then don't assign the column 2 code. You can assign the column 2 code and put a modifier on it till you're blue in the face and it won't do any good. You won't get paid for it, it'll get denied. If not, then your 59 X modifiers may apply. All right, Kathy, I know we're right on the mark, but can we do this last polling question real quick?
Sure. Okay, Christy's dying to know the answer. CPT code 36245 is reported twice. Which modifier applies? 76, 59, or XS? What do you think? CPT code 36245 is reported twice. Which modifier applies? And responses are a little slower than our last question, so this must be a little tougher one. So what do you think out in our audience? CPT code 36245 is reported twice. Which modifier applies? 76, 59 or XS? And for time, I'm going to close the poll. So here's your last chance to throw on a response. I'm going to close it in 3, 2, 1. Christy, we've got 84% of the audience is saying 76, 13% is saying XS, and 3% is saying 59.
All right, so I should say that we are assuming that we have the documentation to back up that the fact that this really should have been reported twice. The answer to this is Modifier 76, because remember, repeated CPT codes do not generate CCI edits, and we are not going to assign Modifier 59 or XS. XS is so tempting because it probably was done on 2 different body parts. This is a code for selective catheterization of the lower arteries, by the way. And usually when we report it twice, it's because we went into 2 different vessels. But the correct answer here is Modifier 76. And as Kathy is taking us back into our presentation, I will just address a quick question that I saw come in. And somebody asked, what if the CPT codebook tells me to use Modifier 59 to report it, or if it's done multiple times? That is the only exception that I am going to say okay to, because the CPT book, I mean, it's written right there. But it is frustrating because we are trying to get people to use modifiers appropriately, and I get frustrated when I see in the CPT book that they're telling people to use Modifier 59 for multiple codes. So are there exceptions? Yes. Why? Because this is coding, and that's apparently what we do. A couple of other tidbits. I know I'm running a little bit over, but this is such a big topic today. Do not use anatomical modifiers on codes that list multiple body parts that are not paired body organs. The example here, code 12001, for simple repair, and the body parts listed there are scalp, neck, axillae, externa genitalia, trunk, and our extremities. Maybe it was done on the right arm, but if you put an RT modifier on there, I have no idea what you're talking about because there are so many body parts listed. Modifiers are not appended to unlisted CPT codes, so you don't have to worry about doing that. And if you want to append multiple modifiers, you can report up to 4 modifiers per code. I have never seen more than 2, I think, in the hospital setting. It's possible you may see more on the physician side. And they do request putting the most specific modifier first, and they being Medicare, in their claims processing manual. Getting paid. The most important thing about getting paid is to check your local payer requirements. You should be looking at your denials on the back end. If you are in the coding department and you are not getting denials back, then you need to ask some questions. I wouldn't just say, no, we don't have denials. I would go back to the billing department and make sure. You want to develop a process for adding modifiers to charge master-driven codes, because they do require, in certain situations, modifiers. And how are those going to get on there? Do you have a coder putting them on, or somebody else? And be compliant. One of my biggest best practice recommendations is that you limit the ability to add, delete, or change modifiers to just trained coding staff. And this was something that we did in one of the facilities where I worked, where we took away the biller's capability of adding, deleting, or changing modifiers because they had not been trained. Now, if they were trained, that's something completely different, but you need to be reviewing medical record documentation before doing anything with modifiers. And also conduct regular audits on Modifier 59 and get that feedback to the coders. There are some other modifiers that I didn't go over in detail today, and I will just call out a couple here that are kind of weird. Modifier 33 for preventive services is the modifier that was developed for the Affordable Care Act. Under the Affordable Care Act, everybody is entitled to get a screening colonoscopy starting at the age of 50, and to have that paid for by their insurance company without any co-insurance. So on the Medicare side, you have a G code that you report, but patients who are 50 don't get Medicare usually, and so you're only reporting a CPT code. Adding the modifier 33 onto that CPT code is what tells the insurance company this falls under the Affordable Care Act and makes sure that that gets paid appropriately. The other modifier is the very last one on this last slide for PT, colorectal cancer screening test that's converted to a diagnostic. Same idea, this is another Affordable Care Act modifier that if you have a patient who came in for a screening colonoscopy, but they found something and had to do a polypectomy or some other procedure and it's no longer a diagnostic code, you put the PT modifier on that polypectomy code that shows this started out as a screening, but we ended up doing something for the patient. And that concludes my presentation for today. There is a list of the references that I used to create today's presentation. And I know that there were some questions that came in, and I know that we don't have time to address them, but I also know that Kathy's going to make me answer them, and you guys will get an email or something. Did I get that right, Kathy?
You absolutely got that right. You are right. We will put together an FAQ sheet and we will send that out in the follow-up email, and I will hopefully be able to get that to you. I would say look for tomorrow night for a follow-up email, which will include the recording link, all materials, and CEUs. And I will also attach that FAQ sheet. So we want to thank you for your time. We apologize that we went slightly over, but we hope you enjoyed today's webinar. Here's a list of our upcoming webinars for the next few months. Check us out on the website, and we hope to see you next month. So thank you for your time. We enjoyed it today. Have a great afternoon. Bye-bye.